We're going to change subject a little bit and talk about UPJ obstruction, check, cut, or construct. I imagine for most people in this room, the first 10 minutes is going to be a review, but it's a topic that's not really talked about much, and there's not a lot of research, and I'll kind of tell you a little bit about that. But hopefully by the end, I'll introduce a couple of new concepts, particularly in the checking and the cutting realm, maybe not so much in the constructing realm. Learning objectives can be found online. So just to get everyone on the same page, what is UPJ obstruction? It's defined as the obstruction of urine flow from the renal pelvis to the upper ureter, and as that little cartoon shows, the resultant is dilation of the renal pelvis, caliectasis, and eventually deterioration in kidney function. Primary UPJ obstruction, of course, is the most common congenital ureteral anatomy found in children. There are about 2,400 cases approximately a year in the U.S., and now with prenatal ultrasonography, most of these are diagnosed even before birth. So the way primary UPJ is considered etiology-wise, there's 4 different etiologies, and I'll go over those with you. The first is called intrinsic, and I think that's the one that is makes the most sense to us. So this is congenital. I would say the majority of these are diagnosed in kids, but some, make it to teenage years, their first, college beer party or something like that, and they get the Deedles crisis, and a few in their 20s as adults. But this is all the things that you would normally think about, so kinks, strictures, bands. By retrograde pyelography here, you can see kind of a normal appearing ureter and then just nothing. So that's a very tight stricture. In this case, there's some caliectasis, but the renal pelvis, as you can see, looks very small. So these are really challenging to reconstruct. In other cases, you'll see more of the classic, so very large renal pelvis, very dilated, and then these abnormalities along the ureter there that look like maybe mucosal folds or multiple small strictures. The second is location. This is called high insertion. These are pretty rare. You don't really see them too often in your practice, but basically when the ureter inserts too high on the renal pelvis, over time as the renal pelvis expands, it kind of moves and twists the ureter and you'll get almost a corkscrew effect. But again, those are fairly rare and we kind of fix them all the same way. Extrinsic is the third. This is more common in adults. About 60% of these are felt to be due to a lower pole crossing vessel, or at least there's a lower pole crossing vessel present. Most of them are anterior, but a few are posterior. And I guess the controversy in this area is this causative or is it coexistive? Because you can certainly get a bunch of CAT scans in normal individuals who have 2 vessels going to their kidney that cross, and they have no UPJ obstruction. But whether it's causative or coexistive, I guess it doesn't really matter. For us who are repairing it, it's important to know that artery's there. And it does have some implications, not just for pyeloplasty, but also for endopyelotomy. And then the fourth is just combinations of each. So, very rarely does one person fall into one of these categories. A lot of people have some stricture disease along with a crossing vessel, etc. So today I'm really going to focus on adult. I'm not a pediatric urologist, but I do pyeloplasties and adult urology, endopyelotomy. So I want to focus on that and just mention diagnosis. The symptoms, again, about 90% of these when they present are symptomatic. Flank pain, these people think they're passing a stone. They come to the ER and they actually have UPJ obstruction. Deedles crisis, we mentioned it. It's kind of the classic sign, but some of these people will actually have stasis stones, UTIs, pyelo associated. And then more and more commonly with more CT scans, we're actually finding this more incidentally as well. So the imaging study of choice is a CT IVP. For an older individual who maybe has a smoking history, you probably also want to do an in-office retrograde or a retrograde at the time of surgery to make sure there's not a ureteral polyp or a protract urothelial carcinoma. And then, of course, the functional study that's been around for years and years is the diuretic renogram, usually with Lasix. The classic study is, hanging up of the tracer, the T-half of the tracer, more than about 15 or 20 minutes. And just as a reminder, when people go up to the renogram, they back up to the renogram. So it's one of the few studies that you read left to right and not right to left. So in this instance, the dark kidney on our left-hand side is actually the left kidney. So probably not so important for us, but you really want to make sure the radiologist knows which kidney is affected, right? And then the classic Whitaker test. So I used to say this as a joke when I was giving this talk to residents. If we ever run out of CT, contrast, and so maybe someday. Well, it actually happened that contrast ran out. So if you need to do a Whitaker test, if there's no, nuclear med tracer and no IV contrast, I guess you could stick a needle in the kidney, run saline in at 10 mLs per minute, and then measure pressure. But I think that's more of a historical test and more a test that we kind of pimp residents on, and not so practical nowadays. So the way I structured this, I thought we would talk about this as a decision tree. And again, I think this will make a lot of sense to you. But let's say you have a patient who was in the emergency room with appendicitis and they noted some hydronephrosis on the left side. The primary care doctor gets a Lasix renogram, because that's kind of what everyone does when you suspect UPJ obstruction. And the T-half is greater than 15 minutes. So the first thing you have to ask, is this patient symptomatic or asymptomatic? And again, majority of people will be symptomatic. The next question, I think, is what's the split function? So of course, anything less than 15% split function is basically an atrophic kidney. If they're symptomatic and they have an atrophic kidney, I think everyone in this room would agree you proceed to nephrectomy. Maybe if their creatinine's 4 and you want to do something heroic, you can try to salvage that kidney. But in general, with background noise is around 10 to 12%. So that's kind of what that kidney is. The other options I've listed here, in addition to nephrectomy for atrophic kidneys, I just kind of did put some of the ones that I did in residency just a couple of years ago, we'll say, but most of these, unfortunately, are no longer available. So balloon dilation is kind of fallen out of favor due to really poor outcomes. Accusize, I'm not sure you can still get Accusize. I did one in residency, but maybe more historical. Antegrade pyeloplasty, there were a few series, and it kind of just went away. And then I put a line through open pyeloplasty, so I hope I don't make anyone upset about that, but I'll kind of show some data there. But really in 2023, it's either a retrograde endopyelotomy, which is our cut, and then an MIS pyeloplasty, which is the construct. So why not open? So I've had this in my talk for a number of years when I give the UPJ obstruction lecture to my residents. But this talk was in March of, this paper was published in March of 2013 about the trends in UPJ obstruction. And the last time I gave this talk, I was surprised. This only goes to 2009. So I said, there's no way I can just give this 2009 data in 2023 to this group. And I looked as hard as I can, and I can find no recent trends in adult UPJ obstruction, at least something that's published. I think most of us just know that we're all doing this robotically or minimally invasively, but there's no one published. So it's definitely a research gap there if anyone's interested in a research project. The closest thing I could find was this paper. This was published in 2018. This is Caleb Nelson's group at Penn. They looked at the Premier, which is a national representative sample from hospitals across the country, about 12,000 pyeloplasties. They had an A, B, C, and D in this figure. I just highlighted the D. The A was infants, toddlers, children, and then adolescents. And I think this graph just shows kind of the trends. But if you look here across the bottom, the x-axis is the years, the y-axis is percentages, and then those colors are the different percentages. So you guys can probably know what blue is. So blue is open, and in 2003, there was mainly open with a little bit of red, which is lap. And then 2004, you see the green, and the green just slowly gets bigger and bigger. So, of course, the green is robotic pyeloplasty. So by 2015, 84% of robotic pyeloplasties in adolescents, again, not adults, pyeloplasties were being done robotically. So I think I can extrapolate that data. I'm happy to talk about that in our session, but I truly feel that MIS has replaced open pyeloplasty in adults, but I just don't have that literature to tell you that 100%. Okay, so moving to pyeloplasty, I thought I would be remiss if I didn't actually just put a picture up here of the Anderson-Hines dismembered pyeloplasty, the tried and true, how we love the let me count their ways, right? So this is so successful mainly because of the universal applicability of it. So you can, any type of ureteral insertion, you can do a reduction of the renal pelvis if necessary. You can put a cystoscope through a port and extract stones. For tortuous proximal ureters, UPJ transpositions, excising anatomy that looks unusual, sending it to path. It really is almost ubiquitous for pyeloplasty nowadays. The two times that you wouldn't do this would be for long, multiple ureteral strictures where you need a lot more of a reconstruction, and then a very small intrarenal pelvis like that first retrograde that I showed you. That would probably be a YB-plasty, and only maybe asked that question on boards or something crazy, but otherwise I think it would be really unusual that you would ever need to do something like that. So laparoscopic pyeloplasty was first described in 1993, and literally 6 years later, robotic pyeloplasty was described, and there's really been over 20 years of data. Usually it's case series or case controls, but as long as it's a meticulous closure, tension-free, and watertight, the outcomes are very, very similar to open. The first three advantages to robotics is, I put them there, is suturing, suturing, suturing. So any of you still doing pure lap pyeloplasties? No one, okay. Well, one person. So every once in a while, you don't have a robot, you had a pyeloplasty booked, but boy, they're not fun. So I spent the first probably 8-10 years of my career doing them pure lap, and then when our hospital got a robot, it quickly moved over. The motion scaling, the learning curve is a lot easier. In fact, it's a great case, a learning case if you're starting robotics. There's usually not a lot of vessels you have to worry about, not a lot of fear. Cost, I put that as a disadvantage, but I think nowadays most hospitals have a robot, but maybe lack of tactile feedback is the only disadvantage that I could think of. I like this study. This was actually Vinnie Bird. He's one of my partners at University of Florida. So this was this was his series. So he did conventional, pure laparoscopic pyeloplasties, and he had a large series, and he had a partner who would do it robotically. So they thought they would chest beat a little and compare their outcomes. The conventional versus robotic failures were very, very similar, and no major differences in any of the things that I'm showing here: EBL, complications, OR time, a length of hospital stay. They really couldn't find any differences between the two. And I think most of us understand that they are very, very similar. It's just that robotics is so much more straightforward to do. So I think everyone will agree pyeloplasty MIS is pretty straightforward. So now we'll talk a little bit more about some things that maybe are not as common to you, and that's endopyelotomy. So a retrograde endopyelotomy, for those of you that don't know what that is, you put the patient to sleep, you go up with a flexible ureteroscope, you arrive at the stricture or narrowing, and a lot of times you can't get a scope above it or even get your holmium laser through it. So you dilate with a small balloon, and then you use your laser tissue settings to make a cut laterally along the entire length of the stricture. And if any of you have ever used a Collins knife to do bladder neck cuts, you kind of make the initial cut and it opens it up, and then you make another little cut and you keep going deeper and deeper. That's similar to the way you do it. So you kind of put your ureteroscope in, you make a cut, you put the scope in, and you keep cutting until you cut to fat. So it's one of the craziest things that you'll ever do if you've ever done it, to cut to fat. And then a lot of people who do this regularly also balloon again, because if you think about it, there's these radial adhesions or scar tissue around the ureter, and you want to really crush those and kind of pop them out. So you dilate again with a balloon. You leave a stent anywhere from usually it's 4 to 6 weeks, a large bore stent. And this is kind of what it looks like when you're done, or when you're starting to cut it. Actually, you should cut all the way to fat, so this one's not complete, but it's close. So I was able to find some high-level data. This is a systematic review published in 2017. This group looked at adults who had laser endopyelotomies. And I will tell you a little bit about this. This is not all primary UPJ obstructions, and I'll mention that. But so they found 20 published studies that were high enough quality for a systematic review, about 764 patients. Most of these were done with the holmium laser. We're really going to focus on the ones that are, primary management. Obviously, secondary management is, let's say you do a pyeloplasty on someone and they fail. you can go back up and then cut that area. I'm not going to talk about that data. That data is not clean at all, but it is an option before going back to a salvage pyeloplasty. But they had 2 in the primary management, and then they had some that papers that included mixed management, so 3 of those actually had enough number for primaries. And they looked at success rates, whether it was symptoms or radiology success rates, and then factors that may lead to failure. So this is their outcome table. Again, I like to kind of make things a little bit bigger, but in general, it's about 200 patients, a year and a half of follow-up. 3 did not report whether there was crossing vessels, and we can talk a little bit more about that in a second. But in general, it's about a 20% less success rate compared to a classic pyeloplasty, whether you're talking symptoms or radiologic success. And then factors that may predispose to failure, what's all the things that you were kind of taught in residency. Those same papers were looked at in this paper. So hydronephrosis, worse hydronephrosis led to higher failure rates. Less renal function also led to higher failure rates. Crossing vessels, the few studies that did publish it, there were worse outcomes. And length of stricture, it's about 2 centimeters. So anything more than 2 centimeters is really where you draw the line. Stent size, so what stent you leave at the end of the procedure, and then stone burden, high insertions, those things were not found to be failure rates. So we're going to add this to our endopyelotomy decision tree. So not only is it decreased success, but less than 25% function, crossing vessels, severe hydro, and 2 centimeter strictures. All right, so let's say that patient who had appendicitis is coming to you and they actually had no symptoms on their, so a incidentally found UPJ obstruction. I think you would treat that like you would any patient who presents with basically an atrophic kidney with no symptoms. There is no need to go in and remove that kidney. You give them your card. You say, call your friendly neighborhood urologist when there's bleeding, pyelo, pain, or if you just don't want a dead kidney inside you, I'm happy to take it out. But in general, there's no indication to remove an atrophic kidney. So then we'll move on to a little bit to surveillance. So this study was published in 2011. This is Jeff Kadedu's group at UT Southwestern, and I think it must have been they were just kind of sitting around drinking coffee one day, and they were all sharing their experience with asymptomatic UPJ obstruction, and they decided to look at their clinical practice. So this is a retrospective review of their clinical practice. These patients would come, had no to minimal symptoms, maybe a couple episodes of pain, but that's all stopped. They excluded patients who had stones, very low renal function, or very massive hydronephrosis. And then they followed them at least for 6 months. So the initial patients that they looked at, they did have to exclude a few patients who did not have follow-up. And then they do diuretic urinograms every 6 to 12 months. Failure was defined as a greater than or equal to 10% decrease in split function from that ipsilateral kidney, pain, or an episode of pyelonephritis. So again, I like these little tables. This is the summary of what they found. They had 2 patients who had changes in renal function, 5 patients who had pain, and one of them actually had both, and 6 who proceeded to surgery. So of the 21 patients that they had, 29% failed, and the mean time to failure was about 34 months. So I went and dug and found 3 other conservative management series, so a total of a little over 100 patients, with a mean follow-up of about 4 years. 20% of these people failed, 20% had pain, 20% had surgery, and overall about 25% total failure rate. And the mean for those who reported failure rate was about 2 years. Say, Canales, you just hit me with a lot of numbers and just kind of, in a little bit of a shell shock. So the short of it is you can conservatively manage asymptomatic UPJ obstruction, and I think you can lean on these data. They're not great data, they're not prospective because these patients are pretty rare, but in the right adult patient who says, why should I have this big surgery on my kidney if I'm not having any symptoms, I think it makes sense. for those patients who were compliant, right? So I like to do a renal ultrasound and a Lasix renogram at my first 6-month visit to kind of get a little bit of both, and then I'll alternate those for at least 2 years. I think the data says if they're stable after 2 years, they're probably they can probably be discharged, and the hope is that should they be in that group that progresses, they'll have pain. All right, so we're going to add this back to our cease, or 75% of patients do well on surveillance, but those who do cease, pain, changes in split function, pyelo, or noncompliance, that'd probably be a good reason to shift them back over to the symptomatic UPJO side and just offer those patients a pyeloplasty and let them go. Is that 20 minutes? Am I 20? 20? Oh, wow. Okay. Well, here's my summary. That's perfect. So the window is narrow, but, people can get through narrow windows. So I think from a check perspective, observation's great. A primary endopyelotomy with a 20% failure rate with these criteria in mind probably is not what we should be offering first line to patients, but there may be some patients that are interested in. And then, of course, an MIS pyeloplasty, the improved morbidity and convalescence compared to open, and then the easier suturing with robotics is the way to go. Thank you very much.